phasing into really the most symptomatic regions that you'll deal with, which is neck, shoulder, low back, kind of hip. But like when we think about low back, thinking also about the sacroiliac joint and sciatica kind of stuff, which is really, both of those are frankly more about aspects of the pelvis and the hip as well as the low back, but they kind of get grouped from a clinical standpoint as low back related symptoms, right? So low back, generalized low back pain is the most costly aspect in the medical care system. It's the number one symptom that you will see. It's the number one symptom that humanity deals with. That's uncomfortable. So the easiest quick hack for either one of these is that you cannot have a low back issue without it having an effect on the hips. And you're not going to really help the low back thing or the hip thing without working on both. But more it's that if the symptoms are being stated as low back in any kind of origin, if you don't address the hips really effectively, you're not going to have any kind of long-standing effect that's beneficial. Neck and shoulder can be a little bit different because we have to distinguish, is it about the skull to the neck? Is it atlas axis and about capital actions and stuff? The easiest example of that would be headache related stuff. I'm more a tension headache person, where it's about the base of the skull. And that can have a variety of causes and reasons. Most of mine now is probably eye strain, stuff like that. But postural things like here, squinting, plus eye strain, and the neck, and the natural actions that happen with the head into those positions. And recognizing that when we do this, all this is short, even though this might be long. So is it basically base of the skull, more the higher cervical region relative to the skull, or is it down here where the lower cervical vertebrae are going to get pulled out of distortion or cause distortion when the scapulas or your shoulders are offset? So let's say I have a cervical disc issue that causes this. The body wants to naturally create some space for where that disc has slipped or ruptured or something. What I will then do, because the body, for sighted people, will always find a way to orient your eyes as level as possible to the horizon in order to help you establish equilibrium and proprioception. Your body, if you're sighted, was a big thing why I mentioned that is I had a big revelation when my girlfriend was going through more of the orientation mobility stuff and talking about developmental challenges that people that are born blind have because they don't have that sensory input to help with writing reflexes and spatial awareness and like object permanence and everything. It's a crazy thing that can affect proprioception, balance, all of it, right? So vision issues later on also can be playing a factor with like how a person is able to move and coordinate the rest of their body and how that's going to interface, especially here. Because a lot of the small adjustments I would make to get my eyes level with the horizon are going to happen with these very tiny actions that I do just at the base of the skull, at atlas and axis. So if I'm a little bit crooked here, right? If I'm a little elevated, all that. Lower down, though, if it's more crooked like this, then I will turn my whole body like that to get my eyes level. So a person won't come in like this. They won't come in like this. They're gonna come in like this. They're gonna come in like this. So this would be a good example of maybe the source of the whole body postural distortion is at the neck. But in order to get the head level, what you now have is something that's going to really mess up everything down the chain because we've changed the orientation of the whole spine. The movable aspects of the spine. the cervical spine and the lumbar spine. With spinal distortions like scoliosis, kyphosis, certain, like lordosis is like where the development is occurring there. The structural element is becoming distorted, was born distorted, and or is developing and becoming more distorted. Can be related to an injury. I have a friend who had a bad injury of T12, L1. Thus, she is in kyphosis, but it's because the body adapted to create some space there for where that vertebrae and disc was injured. Now, with those, really, it's not very productive to think that you're going to change a kyphosis, that you're going to change a scoliosis. What you can do is try to help the body have less stress while adapting to the spinal distortion and the postural distortion. That's likely not ever going to change. Best case scenario typically for people is they can get it stabilized so it doesn't get worse over the course of time. And that's usually interventions that are used with braces and other things. You can get maybe some correction, but really what tends to occur is you can at least stabilize where it's at once the interventions begin and keep it from getting worse too much more quickly. And that's where we can really help too. It's like with scoliosis, identifying a little bit where those curves are. And that one's not particularly complicated because it was just trying to regulate the tone of the muscles up and down the spine and help the shoulders and hips be as adaptable as possible, because the ball and socket joints, especially the hip joint relative to that, is going to have the most ability to adapt. And then once we were at a place where symptoms were reduced, if not gone, then hopefully we just freeze them like that, right? But no way, ultimately, are you going to have low back stuff without it having issues causing things in the hip. And you might as well always assume if there's a neck issue, the scapulas are also involved. You will hear, and this is one of the confusing elements with both areas, is low back versus even hip. People will often confuse, the pelvis with the hip. The SI joint and even sciatica related stuff, it's just the phrasing can be confusing. The shoulder, just always remembering that we have to distinguish in either one of these categories, the shoulder joint from the scapula. Just like how now the bridge here at the lower body is much more fixed, but the pelvis also has its play. So is it truly a low back issue, or is it a pelvis issue? Is it truly a hip issue? Is it maybe more of a pelvis issue? We're not going to have the time to go too much into the pelvic girdle stuff. I think I've shown a little bit of that. There's more videos that with even animations that'll give you a clearer understanding of that. So pelvic girdle alignment, we have those on there. Now, even without really knowing how to correct, like to assess the pelvis and get it torqued and twisted, with that, if we can just try to balance the tone of the muscles around that, meaning around the SI joint, especially at the hip flexors, a lot of times the body can just self-adjust without us like literally trying to shift the jointed elements. So 3 things there. At the neck, it's just that the scapula is going to do something weird, and the dominant arm, that scapula tends to be elevated, all that good stuff. So you want to just be distinguishing the two regardless what a person says, and then you're trying to identify if it's a neck shoulder issue, it's probably more of a neck scapula issue. And a little bit discussed with the shoulder part, there's a lot of overlap here, of course. And the question can be, even if the ball and socket joint has a really bad problem, like a rotator cuff tear, bad osteoarthritis, there may not be a whole lot we can do specific to that. We can regulate the tone around there and try to like make the soft tissues crossing that joint line more happy. But the next piece that could be adaptable and take pressure off of the shoulder joint would be the scapula. Because if that's bad, then the scapula is going to get distorted as the body initially guarded. So classic with either one of these, but let's use a rotator cuff tear as an example. The body is going to want to put you in a sling, right? Now, as far as the shoulder joint itself is concerned, the glenohumeral joint, that's going to be internal rotation, adduction, but then also that protects that. It creates more space for the nerve branches here. See how that kind of gathers everything towards that brachial plexus and gives it more room? So that's the natural adaptation right there. Then what's the other thing that tends to happen is the elevation of the shoulder, like this. Thank you, good sir. So that's a scapular issue, not a glenohumeral issue here. And maybe we can free this up some, but the next piece is going to be this. And identifying that there's like certain confusing things with multiple functions of muscles again, like upper trapezius. Upper trapezius is involved with neck extension, neck lateral flexion. Like in this case, in neck extension, cervical extension, both sides of upper trap work synergistically. Both sides are shortening at the same time and pulling the head, the neck backward uniformly. But if I start laterally flexing, now they're antagonists. One side shortens while one side has to lengthen. Man, then with shoulder movements, they are involved with abduction. It's mostly about stabilizing the scapula, but once we get past a certain range, more like 45 degrees, the scapula does have to start moving to allow for this action. It's mostly predominant at 90 degrees where the scapula really has to start taking over. It's mostly ball and socket joint to 90 degrees or to 90 degrees. Beyond 90 degrees, that scapula needs to be sliding in order for the rest of the motion to occur. So that's the easiest assessment ever, is can a person do this and this? Ball and socket joint, glenohumeral joint is okay. If the resistance is beyond that range, it's certainly scapula. And there you go. Then you just figure out what to do about it. And you've already learned one of the best ones, which is sideline, shoulder shrug, reach for your toes. Pin here, shrug, reach for your toes. That's the one that just is by far the most efficient relative to both neck and scapula, shoulder, scapula related issues. It's that key spot everybody wants a lot of pressure on, and it's the best muscle energy technique that seems to get either aspect of it to engage, because it can be that it's levator scapula, something about more about the neck, or it can be upper traps. It's usually both. That's the one. There's also the firing pattern dynamic there with deltoid versus upper trap for abduction. Deltoid's supposed to be the workhorse here. And deltoid as a muscle pairs with your glutes. So deltoid hugs the ball and socket joint. It has three sections, anterior, intermedial, and posterior. And you can think of those as three separate things because they actually do this. The anterior deltoid's about shoulder flexion, posterior deltoid's about shoulder extension, intermedial deltoid about abduction. Even though we think of it as one muscle, it's surrounding that whole joint. So the fibers here are antagonistic to the fibers here. Three sections of deltoid, three glutes. Gluteus maximus, gluteus medius, gluteus minimus, which basically hug, for the most part, the hip joint. You have other stuff on the front that's involved there. So glutes with deltoids, that's the pairs there. The deltoid is supposed to be the stronger muscle, especially for this action. Glutes are supposed to be the strongest muscle for hip extension. You can see there's some similarities, even though the actions are a little bit different. Like dominant this way, but we're gait stuff too. Glutes with deltoid for walking. Yeah. No, I'm not doing it right. Now, I'm finding my way to isolating the things. Let's talk about the low back stuff first, lower body first. Working our way up from the hip. The deep lateral hip rotators, we visited those. We also talked about the hip flexors / the internal hip rotators. The other ones involved here are gluteus minimus and medius. Those two are predominantly about, especially gluteus medius, are more about abduction. But the anterior fibers are also internal hip rotators. So this right here, kind of all the muscles right by where your pant pocket would be, are the internal hip rotators. Over here, the external hip rotators. With low back dysfunction and hip-related issues, there's a few reasons why, but in the end, the tendency is people get stuck in external rotation. These get too short, and these get too long. What that will feel like when you do assessment is somebody's laying prone, I bend their knee, and I'm doing the hip rotation assessment, and they have plenty going that way into external hip rotation. When I try to I'm leveraging the tibia. So I'm rotating the leg this way when I do that. So they should have lots of movement that way. That's most common. Then we try to bring them this way. I just have the knee bent, so I'm pulling like this. They will have much less going in internal hip rotation. That's just a really common character. Now, people will surprise you, and if they have a crooked pelvis, then it's going to be a different thing too. But there's a real common correlation with low back dysfunction and limited internal hip rotation. When we find that, then the question is, I've already said the answer, which one of these is too short? Those are too short. That's where the importance of compression here and being really thorough is so essential. And it ends up being very efficient because the greater trochanter, if I pull the leg this way into internal rotation, that'll move the greater trochanter out of the way, gapping this area because it is stretching those. So it's a pin and stretch of the deep lateral hip rotators to bend the knee, plant your forearm, and then pull what feels like the leg towards you, but what that's doing is spinning the femur and internally rotating the hip. Moving the greater trochanter out of the way, creating more space for your forearm, and now you're getting a compression plus lengthening, thus it's a pin and stretch. Then once we're there, we can easily have a person activate in either one of those directions. And then you have everything you need for that. That's why I tend to focus on you knowing how to address this area in prone so well, because that's what gives you the leverage and the ability to pull off all those actions. Doesn't mean you can't get them in sideline. It's just that once they have that leg flexed, these are all kind of on tension, and you can work on it, but you're just going to be a little bit more limited. Either you're going to have an adjustable table or a step to get high enough to be pushing on those. And it's a little bit, I find it just a touch more awkward to incorporate the active movement and passive movement piece in sideline. But you can still work on all those. The ones that sometimes you do need to get in sideline are gluteus medius and minimus, because then that top leg up on the bolster, you can come down on those pretty directly. And since they have fibers that are related to internal hip rotation, there is an easier action because I can just have a person push their knee down into the bolster. And that will do a little bit of internal hip rotation. And just one of the quicker hacks. Now you could guide a person and have them do both rotations and do abduction, adduction, all that to free up here. With hip arthritis, if it's a bad osteoarthritis, and I had somebody that had a bad car accident where they had some plating and stuff where they had to kind of put the pelvis back together, putting them in side lying and being real thorough, basically walking my forearm and elbow all the way around that greater trochanter. The only place I didn't end up working too aggressively was on IT band, oddly enough. But just, I'd go on one side of the table and be real thorough. I had to be up on the step. That's part of where getting those steps, those exercise steps. I needed those because I had a fixed table. So I had to get high enough, and then it was just hold and her doing those actions. And it was rotation, not lifting the leg up and off the bolster, rotating at the knee. So I had to coach that a little bit, that we were actually doing rotation. And just real thorough, and then I'd go all the way around, and same thing, real thorough. You can get all that just fine. But a lot of trigger, pointy, nasty stuff will hide in glute medius and minimus relative to hip pain. And if those become tonic, it's going to start certainly limiting hip rotation because of their other job related to internal hip rotation. I do okay. Now we have gluteus maximus off of this, right? So there's gluteus maximus. That one, the orientation I show you is meant in a few ways to help with actually prying it away from the lumbar dorsal fascia and the SI joint. So I'm kind of going to jump back and forth. We have hip stuff, but then we're also going to be talking some about sacroiliac joint stuff. Initially, especially in prone, it's easiest to interface here because you can kind of figure out some placements with your forearm and elbow, like find that groove, place the elbow, try to pull everything up and away. That is an option. I know that it's a bit more clumsy. I only show it because my clients really loved it. So, because it was pulling everything up and away from that joint, right? So it's like, if this is the area that's having issues, just prying everything away from it. And the pressure is going to be on the sacrum. And you have to visualize that the ilium and the sacrum meet at the sacral iliac joint. If I put pressure here, I'm going to create some gapping. I put pressure here, not so much gapping as I might push the pelvis and open it this way. So my intention is that. Or here, I place myself and my forearm in such a way so the glute maximus is being pulled away from the SI joint. And you can also be a bit more precise with that forearm and work your way along that line where a glute meets the sacrum. And that will usually feel like it has a lot of spots too. Working directly on the sacrum, there's no muscle there. Some compressions on it to try to free it up makes sense. But anyway, we remove that. Now we're talking about these. So if you can adjust your table and or your body enough, you can drop your arm from here. Usually I start here on an angle, move that leg that way, this way, this way, this way. Then I'll stand more perpendicular, drop my elbow. So I'm trying to come real on the lateral side of the body to make that contact with gluteus minimus and maximus. Sorry, medius and minimus. That's an angle that I've used. If I do that plus them in supine, really internally rotate that leg and come in with the same orientation of my forearm, then I'll get the rest of gluteus minimus. And bless you. but I'll get the rest of gluteus minimus, medius, and that aspect of IT band. That's my personal choice of how I work on that, as long as I can get the body mechanics right. That being said, no reason why you can't also be really good at it inside line. It's a pick and choose, and ultimately you have to be good at both, because there's some circumstances where certainly you're limited and can only use sideline. Good example with where you couldn't work on the low back as much is like in prenatal. But if we can make the hip as happy as possible, now it can adapt as the low back and the abdominal cavity are having to change so much. So in sideline, that's where you would definitely be sure to work here, even though I can't come here on a lateral refe and all that. All right, that covers the glutes and some of the SI joint. The other correlations, this one doesn't do as good a job. We showed some of this, but this isn't going to show the interface of attaching everything onto the body as much. But visualizing this, here's the scapula. Visualizing that this is what happens with those actions. So elevation, depression. So, okay. Upward rotation. So that's that abduction action. We call it shoulder abduction, but at a certain point, it's no longer shoulder abduction, it's shoulder abduction and then eventually only scapular upward rotation. So here, just ball and socket joint, shoulder abduction. Then around this range, the scapular upward rotation starts. At 90 degrees, the glenohumeral joint abduction is basically done. Past it has to be scapular upward rotation. So this person's got really bad osteoarthritis, where this is frozen, or maybe you call it frozen shoulder. And now when they move their arm outward, it's only scapular upward rotation. Then downward rotation. Protraction. And retraction. And then finding where those muscles are isn't too hard. You know, there's an internal rotator, there's an external rotator of the glenohumeral joint. So remember that the rotator cuff muscles are about the ball and socket joint. The muscles that move the scapula are serratus anterior. We have that one here. That's the protractor that pulls the scapula across the ribs. So that's why it covers so much space on the ribs, and then it starts down here and then comes up and attaches underneath at the scapula. So it's pulling the scapula forward across the ribs. And back here, you have rhomboids, middle trapezius for retraction. For elevation and depression, upper trapezius, remember all that weird stuff I was saying about upper trapezius having to be a synergist sometimes with itself and then antagonist with itself? Well, upper trapezius, lower trapezius. Now rhomboids and serratus anterior, that's pretty much protraction, retraction. For here, that's elevation along with levator scapula. But then lower trapezius is the one for depression. So for upper and lower trapezius, antagonists. For scapular elevation, scapular depression. What tends to get too short? It's upper trap. So that's why compress here, inhibit, lengthen the tissue of that while a person elevates. Then when they depress by reaching for their toes, we're not inhibiting here, we're still inhibiting here. So the conversation we've just had is, you let go and lengthen. Since I'm not pushing on you, you're just left to strengthen and engage more. And that's how we can start to help ideally shift the posture and position of the scapula. And that's the most valuable one I have for you. This aside from thinking about this line back here and this line here, where the glenohumeral joint might be off, and then really remembering, rhomboids tend to be way too long. Most people are rounded forward. So you need to like counter irritate here. Sometimes you got to push through this to get to that serratus. This is serratus posterior inferior, which is an exhalation muscle. There's a mirror of that, looks just like it, right underneath rhomboids, which is serratus posterior superior. You probably won't get tested on those, but somebody has that weird thing here that hurt them after they sneezed and coughed a bunch. There it is. But then there's the other one, the gremlin under the scapula. It's usually serratus posterior superior, which is underneath rhomboids, and it's not about the scapula, it's about ribs. It's about rib elevation. So sometimes I work here, but I'm usually thinking about that. I'm thinking about breathing, not usually worried about lengthening rhomboids. Everybody's rhomboids are long enough. I need to be, that's where the sideline position is key, because that's the only way to get on serratus anterior. So in terms of efficiency, this is where it can be, you initially learned, work on the lateral side of the torso and sidelines, right? But the way at least I think I'm more efficient, I worry about this stuff, the stuff kind of up near the glenohumeral joint, about the shoulder joint. I worry about in prone, when I get that part off the side of the table, and supine, look at the other side. In sideline, I don't worry about that as much. I worry about serratus anterior and some of latissimus dorsi. That's where I'm focusing my attention. And then it becomes more efficient. In sideline, for me, now I'm not trying to cover all these spaces. I've already done one in prone. So now I just worry about the other one. Then I'm thinking about scapular stuff. And I would pay attention more there if it was a scapular related issue, where I pay attention more here if it was a glenohumeral joint issue. All right, I talked more about the hip and the shoulder than I meant to. Now to some of the bridges where, like we talked about how all of these muscles, they attach onto the anterior superior iliac spine. If these get really tight and or psoas is really tight, the quick statement is it will distort the pelvis. So by regulating the tone here somehow, and by having that leg off the end of the table is a great passive stretch for psoas. So without having to get into showing a psoas release, I would definitely say start with working here and having the leg off the table to stretch this, to start with that, and then eventually learn more about psoas release. But if that's tight, it'll distort the pelvis, usually with an anterior tilt. And it's the anterior tilts that, above all the distortions, tend to cause the most problems. So if you can determine an anterior tilt, and if you work in a setting that's more clinical, that might be told to you. In chiropractor, PT, somebody's going to say they have an anterior tilt on their left pelvis. Is there anything we can do about that? Yes, there is. And one is just regulate the tone on both sides, but try to get that pelvis just moving. That'll be one where the contour drape is important, and then lifting the leg, I have to have a knee that bends to show that appropriately. But that way, not a hamstring stretch. I would let this knee be bent and come over and move the leg that way. So I move the pelvis that way, takes it into a posterior tilt. I take the leg this way, takes it into an anterior tilt. So leg up, contour drape, leg up, posterior tilt, leg down off the side of the table, anterior tilt. Both of those actions plus thorough massage, both sides, feel where the resistance is, and do a little bit more where the asymmetry is. One side will feel like it can't go up as high. One side will feel like it can't go down as low. Do a little bit more to balance it out. Scapular stuff. We already addressed that one, and thank goodness that one's not too hard. Probably the one that will frustrate you the most is here. That one will bug you. That's where there is an option. It's not a subscap release, but you can come in supine, kind of pin the scapula like this, and kind of be trying to, it'll feel like you're not trying to go underneath it or anything. I tend to use my soft fist for it, but pin latissimus dorsi and teres and all that, and then a person reaches for the ceiling. So that would look like as the therapist has a soft fist here and the person's reaching. The idea is to kind of try to pry latissimus dorsi off of serratus anterior and create some space there. Well, that's going to be one where I'd have to demonstrate it for it to really make sense. And pecs for days. And sometimes pecs in different orientations. Revisiting not just this one, but you can start to get braver knowing to not get the tubes, but to come in at the pecs in this angle, to lift them up and away. Now, moving on to, let me get this stuff away. The torso directly. The nice thing is I mean, is kind of an opinion, but also I'm pretty confident that I'm right, that so much of cervical and lumbar spinal issues are best managed, not fixed, but best managed by balancing out the scapulas and the pelvis. And if you can get those sorted, then the movable parts of the spine are not going to be nearly as stressed, right? And there may be nothing you can do about the spinal fusion or about the disc that is permanently compressed, or the ruptured disc, all that kind of stuff, right? You can't do anything about that, but the most adaptable parts of the body are going to be the ball and socket joints, and keeping in mind the elephant ears, the pelvis and the scapula along the way. Once we're to the actual bridges, this is where finally we have this guy. I appreciate Logan bringing that one. Now I have this cross section. So here does show serratus anterior. That would be the orientation actually that I would use. This would be a very small person I'd be working on, but hey, we can make it work. Instead of a soft fist, we're gonna have to use fingertips, right? But this would be that orientation. How I could come in and just try to hold all that down while they do some actions. The action will usually be asking them to reach for the ceiling because that'll cause that scapular protraction. But now we can remove this. Wow. And again, showing that serratus anterior. But then this gives us a, let me get the arms both out of the way. Wow. There, that gives us a better view right here. See that line of how latissimus dorsi? Now, latissimus dorsi is a really cool muscle because it's the true bridge, essentially from your hip all the way to the opposing shoulder. These fibers, look at how they map out. White fascia, interfacing with IT band, muscle tissue, deep fascia, at the sacroiliac joint into the lumbar dorsal fascia or thoracolumbar fascia. Same thing. Thoracolumbar, lumbar dorsal. I think thoracolumbar is actually used more. I don't know why I have lumbar dorsal more on my terminology. Same thing. But look at the fiber direction of glutes, right? So it pulls you in such a way that as we do these actions, it's kind of going across to here. Now look at the fiber direction of lats. See how it just continues that line? All the way to the opposing shoulder. So in gait, That's this, from this hip to this shoulder. Thus, latissimus dorsi is this direct bridge. It connects onto the humerus, all the way down, and basically smears in and becomes glutes. So you got to think of this as one big X pattern. With lats, you can get on them some in prone, don't get me wrong, but that's the other reason why in sideline and or even supine, it's about creating space between latissimus dorsi and serratus anterior. Can I get that line freed up so that they can function independently? That will be a big part of helping with any low back issue and or shoulder issue. That's how you gotta get both sides of it. Now we've seen plenty of demonstration, I think, from me about working in the low back in this orientation. In sideline, keep your forearm oriented towards the pelvis so you can bump into it and then dive straight down. Deep to that, you have the obliques, but then deeper, you're gonna end up with quadratus lumborum and even psoas. If you free up that line, you're going to affect psoas. And then if you work your way slowly more posterior, which all that would usually look like, a person is laying on their side, I start where I'm coming more straight down into the table, and then I work my way more and more posterior. That's the way that I can start getting more on, then it'll be all that lumbar dorsal fascial structures. So most superficial, latissimus dorsi. Then we go underneath of that, and then we're in all the erector spinae paraspinal structures. If I can orient my elbow, where it's kind of just stuck right there at the nook where L5, S1 starts, that's usually the best place you're gonna have to get onto that really sensitive area that people do need work on if they have SI joint problems. Boom, boom, boom. Be thorough. And then the simplest intervention is breathing, but even almost as simple as it's that lifting of the other leg. The bottom leg lifted up, those adductors cause a co-contraction of these lateral flexors. And it's just a huge win. Now, from there, that one we've seen plenty of. There are other videos out there specific to the lateral raphe. I did a big one on that one. So lateral raphe spelled like Raphael, R-A-P-H-E. That'll show how to work through there really good. Up here, that's where in sideline, trying to get your elbow set so you're going along that line and a little bit right onto serratus. That's what's essential. All right. Here is the upper trap part. And so coming up to the neck, I don't find the low back too hard. I think that the only thing you need to keep in mind is that you can do a good amount of it in prone, but if you're really going to be super effective here, you got to work on it prone, you got to work on it sideline, and then don't underestimate the value of that pull action, of reaching across and pulling. If you set your forearm such where you kind of dent the side of those obliques, that does a lot to all these abdominal muscles. So I reach around the person. If I can, sometimes I'll just use one hand, but I mean, I'm trying to get all the way underneath of them. And then I have them, their knees are always bent, so knees bent like this, and I have them rotate this way, and it creates that big twist. But as they're twisting, my forearm is being pressed with their body weight into the obliques and deep to them transverse abdominals. If you couple that with just a little bit of a push on the side, we don't have to be going after the midline too much initially, but do try to keep in mind working on those abdominal muscles. And you don't have to spend a long time here. If somebody has low back problems, this used to be where I would just end sessions. We would do all this stuff. So prone, worked on it some. Sideline, really get the deep release stuff done. Supine, wrap everything up, do some stuff with the neck. We'll talk about that in a sec. But then the last thing would be, they get to relax. And I go, okay, I'm gonna do one more thing for your low back. Bolster out, knees up, feet flat. All right, okay, I'm gonna find my way. Usually I didn't even have to drape. I could just create a little window with the drape, go underneath. Ideally, I want to be all the way to their spine. If they're a very large person, you might be limited. So that's where you want the table low or to be up higher, all that. If I can get all the way to at least this side of the low back and just hold on for dear life. It's like where you really drop your butt to hold on. That's where the pressure comes. You get there, and then as you drop, your forearm is coming into the side of the obliques. And then they roll their hips. All I have to say is, right, take your knees one way and then the other way. That also, if I can get my hands placed like that, can do good stuff for maybe getting the pelvis to shift, maybe getting the SI to shift, all of that. But I get to let them play with how brave they want to be with the action. I just brace and hold. And then they rotate that way ideally, and then toward me. A couple of times, and then I come back over. I give this side a bend and a smush. My intention a little bit is to bend rectus abdominis. To give that just a little bit of a bend, and then going around and doing the same thing. Pull, rotate, bend. Good. And the other action for the pelvis and low back, hips, everything, is that having them push their knees together. So hand on one knee, hand on the other knee, they squeeze their knees together. Sometimes it gets called the shotgun technique because in many cases that will cause the pubis symphysis to pop, which is maybe setting the pelvis in a slightly better orientation. I also use that one because it could do a push together, pull apart, push together, pull apart. A way to activate the abductors and adductors of the hip, which are related to balance. And I just assume everybody has bad balance. So it's a nice way to end the session with something that kind of wakes the person up and especially activates their balance muscles, which if they can, one, they're woken up so they're not going to be as dizzy and sleepy. But two, when they get off that table, I want their balance muscles to become more in charge so that their low back has less stress. And it's the balance muscles of their hip. I have a system that I try to work on. It's like massage the daylights out of everything and try to leave the glutes and the adductors and abductors stronger. And that is a very, very general formula as a way to take stress off the low back. That being said, the adductors do usually need work because the hips, people get kind of stuck together. All right. These get short. The pattern is somebody's sitting like this. Where are all the Ks? Easy to find the flexion and extension ones. Usually even easy to identify the rotation ones as you move a person's body on the table. But remember that they're also stuck in adduction and adduction. This is usually super tight, and these are super tight. And here. Here, here. Here. But not here. And not here. This needs to be massaged and strengthened. Massaged, strengthened. All right. Now, a little bit with this. We're doing okay. Opening up our amazing little model here. Take all this off. Try to visualize what I'm about to show you, but thinking about how important, that'd be great, right? It is Halloween season.
I got that here.
Sideline. Prone. The ribs. I know I've said it enough, but always visualize them if they're stuck this way. They're stuck in an inhalated, elevated state. You kind of push them down. When we create the squishy elements of the ribs, that's what you're actually feeling. It's not like they're moving too much, like truly inwardly, right? You have the sternum and the spine stopping that from happening. They're folding a little bit downward. So if I make sure my applications are predominantly toward the pelvis in prone, I'm pushing those ribs down a little bit. So I hold those in all those spots. Here, here, have them breathe. Now I'm affecting the respiration related muscles, but also maybe getting those ribs a nudge in the right direction. Same thing in sideline. Here, pushing the ribs down that way. Supine, here, pushing the ribs down. So for stress management and upper respiratory related issues, that is already pretty much the formula. Make sure you're applying force on all areas of the rib cage. Might as well get the double benefit of affecting the muscles that move the ribs and have them breathe. Mom does the more aggressive one sometimes, which is have a person cough. If you want, now that's the more extreme one, and it can be a good thing to do, especially if a person is just getting over an upper respiratory thing, where maybe the coughing caused some of the problem, right? A other more gentle version of that is have them do an exaggerated inhale, hold their breath for a few seconds at the peak of the inhale, and then good long exhale. That holding of the breath acts as an isometric contraction of all those respiratory muscles, so you can get them to all engage, and ideally, as they let go and go into an exhale, those muscles are more prone to eccentrically lengthen as you're squashing them. So, hold, good compression, okay, big deep breath, hold, you're doing great. All right, good long exhale, and as they exhale, I kind of follow the ribs in, try to squish them a little bit further, hold them there, pin the ribs in that more exhalated state. All right, another big breath. I try to hold the ribs, try not to let them push me out. Hold your breath a couple of seconds, and then good long exhale, and done. And you could do that everywhere for the serratus, posterior, inferior, and superior ones. You'll be compressing serratus anterior, but really when I'm doing that, I'm thinking more about the intercostal muscles. I'm trying to get them to shift. Then here, pec major, pec minor, if I'm compressing those, then I'm getting them to maybe release, but I'm also getting the breathing stuff. Now, what we're not pushing on while we're doing all that is, wow, the diaphragm. So if I'm holding all those ribs down and keeping the muscles that are accessory breathing muscles, these do need to function, especially when you're in like a cardiovascular, sympathetically aroused state. You do want those to engage because they create more room for the lungs for you to get a little bit extra oxygen for your muscles so you can run away from the grizzly bear. But the aspect here is that we want a person to downregulate and stop using their upper chest and accessory breathing muscles like that. So if I pin those and turn those off, now I'm sending a signal that, hey, diaphragm, you're on your own. You have to do more if those helpers are now being squashed by me. But it covers that whole thing. And it's a good visual for you to reflect on how much space that covers. Now, have you gone into some of the digestion stuff yet? Okay. Look how much space that takes up. We're mostly intestines. As we massage, if a person breathes better, that is moving the organs more, right? If a person is stuck like this, now when you breathe, the organs aren't being massaged. Good breathing with your belly keeps the organs kind of having this little bit of a bellows action, meaning that they're being moved around each other. They don't get stuck to each other. And it does, good abdominal, diaphragm-based breathing assists peristalsis. Now, you imagine when you're really, really constipated, breathing feels harder. You're full of crap, but it does affect breathing. You can kind of think about how, so one can affect the other. I start with seeing if interfacing with breathing can help with digestion things. And then you just be sure you do that abdominal work, and that kind of smushes everything around a little bit. But then you can get more precise. But if you think about breathing and you make sure you do that low back and kind of push on the sides, you are affecting this too. And just remembering the principle that good belly breathing affects all these organs very much. All right. We did it. That's the low back stuff. All that's left is a little bit on the neck. See if I can put this back together. That'll be a good model for exploring. We have that one too, but this one, although smaller, is way more precise. So you'll have two of them to be able to open that up and think about that. With the diaphragm, sometimes it gets taught to work along the rib line. They'll call it a diaphragm release, where you can feel along the bevel of the ribs here, right? The diaphragm's up and inside like this, though. But we create space along rectus abdominis. We can distort this, and particularly this line, where rectus abdominis sits on top of the obliques and meets the lower ribs. That is a place where you will find a lot of extra shortened tension. Dividing the abdominal muscles in half, this tends to be too long and weak for people. This part will get short and tight, especially related to bad breathing. So there is something to working along that rib line and trying to kind of, as you push in, you're pulling, here's the ribs, here's the abdominal muscles. You're stretching away from it, right? So you don't have to be too crazy with that. I usually go over the sheet for this. Don't go too central. Don't break off their xiphoid process. Be off to the side just a little bit, and then you're not on it. That's that little point, right? Don't be on that. Don't be on the solar plexus. Don't be on the triple heater. Be over to the side. And then trying to pull away. It doesn't matter which way you do it. Sometimes it can be easier to kind of hook and pull across body, or to stand on the same side and just work your way along that rib line. But usually right here is where some kind of weird spot is. It'll feel more toned. It'll have a sensation to it. My initial abdominal massages tended to be this big pull, a big push, and then more point work along this line. It feels more like a therapeutic kind of sensation as opposed to just right? And it is, and it could be, if somebody calls it a diaphragm release, leave it alone. But what you are doing is you're freeing up the muscles here, where if they don't let go, this is the area that predominantly needs to lengthen to allow that diaphragm to drop into inhalation. If these stay tight, then I'm stuck in a girdle, right? So, yeah. Right. Now, talking about breathing, that's going to be, all the stuff low back. You can think breathing is involved. Quadratus lumborum, for example, attaches onto the lower ribs, all that. The neck muscles, basically every single one of these can be a synergistic upper chest breather. It can be an accessory breathing muscle. I found it, accessory breathing muscle. Because they all tend to attach somewhere, either close to the ribs, on the scapula, all that kind of stuff, right? So sternocleidomastoid. Attaches onto the sternoclavicular joint. Thus, if I wanted to lift my sternum up to breathe, you see it engage? Right there. So, sternocleidomastoid, which can mimic migraines in trigger point phenomena, can be tight because of upper chest breathing. Or you have bad migraines and you're stressed out and you start breathing bad. See how like being in pain and being stressed could cause upper chest breathing? And there you go. So I ultimately say you're not going to have a bad neck issue without it affecting breathing. So you might as well affect both, right? Upper traps, we already talked about how easy that one is. The same action would help out with levator scapula. So easy peasy. You could do that in supine a little bit if you wanted with a soft fist, but sideline is going to be the best. Up at the base of the skull, this one's not going to give us a cross section down to the suboccipitals, but you've learned that one pretty good, where it's just be thorough though, because you can be real posterior. That action is going to be one where my elbow angle is more acute, so I'm more posterior, and then I flatten out, and I might glide across just enough to get onto a portion of sternocleidomastoid. And then I can, through all of this, be thinking about breathing, but also the tiny head motions. You could do the oculomotor things and all of it. But that's a way while you're here to be a bit more thorough and affect those. Scalenes are scary to work on, so I tell you to not worry about them as much as considering this is one time when a little bit of a stretch makes sense, because they're lateral flexors, but they attach onto the ribs, so they're big time involved with as accessory breathing muscles. If in sideline or other orientations, but this is going to be the easiest one. I've seen a lot of osteopaths and PTs do it in supine. I think this is a lot easier. Just reach underneath, pull enough. You may have to even remove the pillow for this one, so you create a nice stretch, because we're pulling the scapula down, their head's just dangling, and then just breath. There's no extra pressure, there's nothing like that. You're just letting gravity do the work while you hold the scapula down. So you're holding the scapula in a depressed, downwardly rotated, retracted position. You're pinning the scapula in a better orientation and putting the neck, particularly in this case, the scalene muscles on tension and having a person breathe. And while you're also doing this, you're holding the whole rib cage down, which they attach onto the ribs, and there you go. That's the safest initial way to interface with those. The scalenes can get so tight that they start impinging nerves and cause some radiating pain down the arm. So if people have radiating pain down the arm, places to consider are freeing that space up, which would be just get all this, do that, and then along this anterior line of pecs. But it's usually something, if it's not at the spine, it's happening at the scalenes or it's happening at pec minor, is where most commonly that impingement is occurring. You can see how if we hold it like this and they breathe, pec minor attaches onto the ribs too. So we're getting a lot of cool interfaces by just holding the skeleton still while they do the breathing to get those breathing muscles to free up. Sternocleidomastoid, scalenes, suboccipitals. Those are the ones that you go after with almost any neck/headache issue.
What do you do for the person who says, I just feel like I have to crack my neck and it won't crack?
It is a good one. So,
You relax the muscles around it.
as much as possible. So, this will be a place where, thank you, that's actually a very good question that will be a good end to all of this. The only other thing, real quick, is a really good scalp and head massage. Remember, you have occipital muscles up on the occipital bone. Suboccipitals, occipitals. Occipito frontalis. One muscle. Well, it gets taught as that. It's even in the book as that. Temporalis. Boy, those control the tension of the scalp. Nobody wants a hat that's too small. So it just, as thorough as possible. That's why my orientations are always trying to pull everything towards the crown. Trying to mush things this way, mush things this way, mush things that way. It also ends up working in kind of a lymphatic system, because if I do that, it's kind of a lymphatic drain for the scalp. You'd go further and do the rest of it down the face, but you're just pulling everything to the neck is all you're doing. Estheticians, you'll see that same formula. There's like gua sha stones for like self-care that teach you the exact same formula. For the actual cervical vertebrae, neck popping people, who I tended to be one, and it's been one of my great successes to stop popping my neck. But it's a heck of a journey to have to live with it kind of always feeling stiff and wanting that to free up. It's a place where, if you can, gotta get brave and really super aware of how those cervical vertebrae are oriented. And it's not anything really all that complicated. It's just that you have to be really close to the spinous process. And they're smaller, so it'll feel a little scarier. And because the muscles thicken up so much here at the base of the skull, you won't be able to palpate them as easily up here. You always be able to find C7 though. Find your own C7. That's the big bony bump that everybody thinks is like the beginning of their, their hunch. You can always find C7 and then track that up and see if they start to disappear. You can find them most of the way all the way up, but then eventually it's like, where does the next stop and the skull begin? Right? Now, in order to be really on what would create that sensation, is you got to be just next to it. Because you have the erector spinae muscles. You have splenus cervicis and splenus cervicis. So those are unique to the cervical region. Splenus cervicis, splenus capitis. Both just pretty neck extensors. But then deep to those are all those little tiny paraspinal muscles, like the multifidi and all that kind of stuff. Now, since there's all that overlap, of just, from the vertebrae, little tiny muscles that attach literally like each vertebrae to each other. So those are the paraspinals. Then on top of those, the erector spinae. And then on top of those are these big surface ones. So we're pushing through a lot of surface stuff with the intention to be affecting those paraspinal muscles. But then you got to be right next to that spinous process to be actually sure that you're going to be putting stress on the paraspinals. And that's when we're, even on a tiny model like this, that one won't work. I have to be where my elbow in this orientation is sitting right next to the spinous process. So like I find it and then I'm right here. That's the way I do it. It took a little while to get confident with it. It helped that I had so many neck issues that I had felt a lot of people like Mom work on me to kind of get a sense of what felt right. Since I knew what really felt right there, it was easier interface. And it was a place where I got better here to start than other places because I had those symptoms. So I could kind of just reflect on it better. Now, the other version, and is this for you?
No.
Okay.
I just...
Yeah. Does anybody have a neck that bothers? No? Okay, well that's good for you. The other one. Now here's the thing. There is a lot to be said for working on that part of the neck. One, because it just feels so dang good in supine. But you cannot, I promise you, that will be a place where you hurt your fingers and your wrists if you work on the neck too much in supine. You got to get a big chunk of it out of the way here. Get upper traps and levator scapula. At least come in through here. I usually do at least 3, if not 4 times, depends on the size of the person's neck, to really work my way up and up the cervical vertebrae. Then I kind of try to go across a little bit, get some of the suboccipitals, or really just the attachment site. Then I swoop back, hold here, come up to the occipital base, dive in, hinge my elbow so it's more posterior, get those suboccipitals if they're a tension headache person. And then I try to make sure I get on sternocleido. Some additional training and stuff you would want is to a better understanding of how to get on scalenes and sternocleidomastoid. We might be able to have time towards the end of class, but those are just real delicate and you have to be careful with it. But as I said, as long as you do this, you do pretty good with a stretch. And in supine, there's also a really, really good stretch for scalenes and sternocleidomastoid. So as opposed to doing the more targeted stuff where you really do need to be very careful. But there are direct ways to release these, just like there's a direct way to release psoas. Here in supine, that is such a roundabout way of answering questions. The trick here is instead of, it's convenient to be able to take those arms off. You're really convenient that everybody was just this small. The trick here is not to be like this. It's to come around to the side, bring your hand underneath, sloth claw. It's your fourth and third phalanges, your fourth and third digits, where you can apply the most pressure because you can bracket it with the pinky, you can bracket it with the index finger and support them. Then curl them, and the weight of their head will do most of the work for you. But if you stand like this, you lose a lot of that mechanical advantage. And the value here, this don't get me wrong, it feels nice. But those vertebrae usually need more help related to lateral flexion and rotation. Not as sometimes extension stuff. But when people get like this, they just usually need to, if you get their shoulders lined up better, their neck will go further back into extension. So if I see somebody like this, they're a sloucher, I don't worry quite as much about the neck. I'll get the suboccipitals. As long as I can get their shoulders back, that'll go with it. But if they're one side neck and something's distorted and all that, then it's usually more of like there's some planar things that can occur there, but it's usually there's the lateral flexion part or that's the rotation piece. And how do people crack their neck? Or, right? So that's what the actions we're kind of replicating. But don't do no popping. Those fingers braced, now I can try to mindfully set these fingers at each vertebrae. I don't usually worry about C7, I go to C6. I can find C7, come just up to it, there we go. Hold, and usually I have them do, at the neck, start out with having them do the actions. It'll feel very good to do. Now, with my fingers, especially those lower cervical vertebrae, sometimes you can get kind of a hook on it, right? And this is what the osteopaths will do, is they'll kind of try to nudge the vertebrae. They'll try to assess, is it just a little bit shifted over like this? They'll get their fingers over on that side and kind of, come on. Or they'll try to do a little pressure upward to create little rotations. That assessment is just very precise. You could reach a point where you kind of feel up along those spinous processes and see, does, this is what they're just little wings. Are they a little off this way? A little off this way, right? You can get that precise. I go, each of them should have attention. C6, C5, C4, all the way up. As high as I can. And then eventually you lose them and you're pretty much on the suboccipitals, or the common attachment site for all of those surface muscles. But if you do that with these small actions, it's not aggressive. It's pressure up enough and then a little pull towards you, or extending your fingers so that the pressure feels like you're pushing more up into them, right? So it looks like this or this, or a little bit of both. Hook, pull, push up. Hook, pull, push up. Hook, pull, push up. A little bit mechanical. There, kind of smear it. Ooh, smear, woo, smear, and woo. And it feels wonderful. And then holding at the base of the skull, coming around, holding at the base of the skull, little cranial sacral, coming around and doing it all again. What this is better for is now you assessment-wise get to compare both sides, right? So it's a better assessment tactic, and it's much better for you mechanically with your hands. It just takes a little bit longer. So that's a great way to end the session too. Here, drop our traps, smush, take a couple deep breaths, a little swoopy. Here, work on one side of the neck, swoop around, other side of the neck, cranial sacral, head smash, swoopy, and get out of here. All right.
Done.
All right. Perfect. That's that.